Welcome everyone to Volunteering for Seniors virtual webinars, which is exclusively for senior citizens and their family caregivers. This is Pratima Penumarthi, founder and president of Volunteering for Seniors. Our mission, as most of you know, is to reduce loneliness and isolation among seniors and help them stay more energetic. Since the year 2021, we have been conducting virtual webinars, talk shows, conferences for senior citizens, presentations, general sessions, all that which focuses on supporting health and self-care for seniors and their caregivers, and also for the caregivers of individuals with or without dementia across USA. To know more about our organization, please visit our website, volunteeringforseniors.org. So before we start with our topic today, I just wanted to say that there are plenty of changes we can expect to see and experience as most of us as we get older. Things like worsening eyesight or having wrinkles, which are all very clear signs of our body's aging. One problem that adults, senior adults, or I can say older adults may face during the aging process is the development of urinary incontinence or bladder leaks. Urinary or fecal incontinence is a very common and distressing complaint in the elderly, as we all know, and it is more than inconvenient. It can be life-altering, leading to early retirement or even social withdrawal. For some people, it's depression and even loss of independent function. So today's topic is we'll talk about diagnosis and treatment of urinary incontinence, and to share with us more information, we have with us, and we're very, very glad to have with us Dr. Vikas Marcia, who's a board-certified physician in female pelvic medicine and reconstructive surgery, urogynecology, obstetrics and gynecology, and lifestyle medicine. He has a Bachelor's of Science in Biomedical Engineering and Electrical Engineering from Johns Hopkins University in Baltimore. He received his medical degree from Rutgers Medical School, New Jersey. He completed his internship residency and subspecialty training, which is in obstetrics and gynecology from Temple University, Philadelphia. He's among the first in the United States to receive subspecialty board certification in female pelvic medicine and reconstructive surgery. Dr. Marcia specializes in operative and non-operative management of all diseases, and when intervention is required, a minimally invasive technique. That's what he's done. He's highly trained in vaginal surgery and robotic surgery, and he also provides minimally invasive surgical options. Dr. Marcia is married with 3 children, and his wife is also an internist who we spoke last time, and she works at Compass Medical in East Bridgewater. Good morning, Dr. Marcia, and we are so glad to have you today.
Good morning, Pratima. Thank you for that very warm welcome. It's my pleasure to be here, and I think with the goal for volunteering for seniors in terms of helping seniors maintain a healthy, productive, functional life into the golden years and beyond, I think this topic is really at the heart of that, and it should really help empower individuals to become more free and liberated. It's a very challenging thing to start out from birth to be incontinent and not being toilet trained and wearing diapers until we go through 2-3 years of age and start becoming toilet trained, only to, for no fault of ours, as we get older, potentially go back into diapers. It can be very debilitating and humbling and confining. So I'm very excited to talk about this. This is a topic of passion for me. I've spent the past 25 years in diagnosing, treating, and managing women with these specific problems. So I'm looking forward to having this discussion and the presentation and any discussion afterwards.
Thank you very much, Dr. Vikas. Could we start with the presentation? Of course, there's so many questions that will follow along. It's more about, why does it occur? What are the causes? What are the treatments?
So thank you for having me. It's my pleasure. Thank you for that very warm welcome. I think most of that information is here. So this is me. This is what I look like. I have my practice in Brockton, Massachusetts. It's on the Good Samaritan Medical Center campus, but I'm not a employed physician of Good Samaritan Medical Center. So why do people leak? Why does anyone leak, right? So first of all, what is the bladder? What is bladder leakage? It's a condition which is associated with a weakening of the pelvic floor, and it can progress over time if untreated. It's characterized with the sudden loss of urine at untimely manners, and we refer to it as urinary incontinence. So a brief overview of what's the urinary system. Urine is made by the kidneys in our body. We have two kidneys. Those kidneys drain their output through two ureters, and that goes into the bladder. In the bladder, the urine is stored through the course of the day as it's made and collected. And then when we're at appropriate locations like a bathroom, we void, and that process of voiding is called micturition. And in micturition, the bladder muscle contracts and the urethra relaxes and allows urine to pass. So that's effectively what our bladder is. A relatively simple thing, but it can create havoc and problems if it's not working properly. So here we see the bladder filling through the course of the day. Once it's full, the bladder muscle contracts, the urethra relaxes, you have emptying of the bladder, and then you have an empty bladder, and then that process starts all over again. So storage and emptying. In storage, the bladder relaxes and the urethra contracts. In emptying, the bladder contracts and the urethra relaxes. Very simple functioning of the bladder. So what goes wrong? What are the big problems that are associated with urinary incontinence? And they could be a variety of different things. So one is there could be a storage problem, that the bladder muscle is contracting inappropriately, or we can have weakening of the urethra, which acts as a continent mechanism to allow urine to either stay in or come out. So depending on the type of incontinence that you have, different treatments are available. So there are basically three main types of incontinence. One is called stress urinary incontinence, and the other is urge urinary incontinence. And when you have a combination of these two, it's called mixed urinary incontinence. Stress incontinence, not like under mental stress, but you're physically exerting your body and doing strenuous things. That's what anything that leads to an increase in intra-abdominal pressure is referred to as, with leakage associated with it, is referred to as stress urinary incontinence. Whereas urge urinary incontinence, which also includes overactive bladder. So overactive bladder is like the sensation that you have to go, and urge incontinence is having that sensation that you need to go associated with a leakage of urine. So this can create a lot of frequency, urgency, the need to go a lot through the day, or waking up at night, which is referred to as nocturia, or if you wake up at night, or if you don't wake up at night and you wet the bed, enuresis. So there's a variety of things which can go along with this urge incontinence. And when you have symptoms of both, it's referred to as mixed urinary incontinence. So bladder, it's common, but it's not normal. Over 60% of adults in the US experience leakage. And that's a staggering number to kind of wrap your head around. But as few as 25% of women with incontinence actually seek care. So it's a pretty common problem, but very few people seek care for it. And here we're looking at the incidence of comparison of various diseases. We all talk about heart disease, diabetes, hypertension. Believe it or not, incontinence, the incidence is far greater than any of those other diseases. So it's not a trivial disease. It's not a life-threatening disease, but as we'll talk more, it can be a very deprecating and debilitating disease nonetheless. So what is the economic cost associated with incontinence and overactive bladder? As you can see, the costs are just increasing from 10 billion in 87. We're probably exceeding 83 billion in 2020. And the cost it's a physical, psychological, social, along with indirect costs associated with purchasing incontinence products, not going to work, missing productivity. All of these things kind of get factored in. So it's not a trivial amount. That's, almost $100 billion. So what puts you at risk for urinary incontinence or bladder leakage? Primarily it's weakened pelvic floors for women, pregnancy and childbirth. Certainly the process of aging and menopause and loss of estrogens can factor into it. Constipation, being overweight or having a large body mass index, smoking, chronic cough, any of these things which can lead to a weakening of the pelvic floor can certainly lead to bladder leakage or urinary incontinence. So specifically, if we're talking about pregnancies, it's childbirth. Vaginal childbirth puts you at a higher risk than having a cesarean section. If you're occupationally lifting heavy objects and things like that, that can put you at a risk. Certainly genetics play a factor as well. If your mother, other sisters, siblings, grandparent, they have incontinence issues or pelvic floor defects, that can factor in. The big thing with genetics, it's collagen disorders. And again, with genetics, it's a very common statement made in lifestyle medicine. It's that your genes load the gun, but it's your lifestyle that pulls the trigger. And what that basically means is that your genes predispose you to certain diseases, and that may be 10 to 15%. But the greater preponderance of that 85 to 90% of the burden associated with actually manifesting and developing a disease is not based on your genes, but it's based on the lifestyle which we choose. It's very convenient for us to blame our genes and accept that this is our fate, but in reality, it's not really our genes, it's our own choices and our own life, which leads to this thing. So certainly medications, especially in elderly.
Oh, we lost Vikas' voice.
Somehow I got muted. I am unmuted now.
Yeah.
Can you hear me?
Yes.
Okay, great. So the impact of drugs, certainly calcium channel blockers like nifedipine, NSAIDs like COX-2 inhibitors, all of these things can increase urine production. The calcium channel blockers can cause relaxation of the urethra. Drugs which can induce constipation like calcium channel blockers, anticholinergics, and narcotics. Antipsychotics, which limit our mobility and ability to get up and get out of bed, go to the bathroom, or just even walk in general. Things which are sedatives or benzodiazepines, again, these affect our mentation and make us slow. ACE inhibitors with stress urinary incontinence, and drugs that affect the lower urinary tract function, which decrease contractility of the bladder muscle, can be anticholinergics or calcium channel blockers. Things which on the urethra increase the urethral tone are alpha agonists, and those which relax the urethra are alpha blockers. And certainly diuretics will lead to an increase in production in urine. So as we already discussed, childbirth increases your risk 1.5 to twice as much as having a cesarean delivery. If you're obese, so that's a BMI greater than 30, and it may apply to even being overweight. So the BMI range is between 18.5 to 25 is normal, 25 to 30 is overweight, 30 and above is considered obese. So being obese with the BMI greater than 30 increases your risk of incontinence twofold. And actually losing that weight can be protective. Surgery, pelvic surgeries for women, having a hysterectomy can increase your risk from 2 to 6-fold. And the lowest odds are if you're having the surgery for benign reasons. That means it's not a cancerous surgery. The highest odds are if you're having it to correct prolapse, because if you have prolapse, it begets more prolapse in the future. But if you have an incontinence procedure performed at the time you have your prolapse corrected, you actually don't get that. Age, certainly as we get older, our muscle tone decreases. We're more predisposed to becoming obese, potentially having surgery, hormone replacement. A great many women are not on any kind of vaginal estrogen or treatment to help improve the quality of the vaginal and urethral and bladder mucosa, and those all have estrogen receptors, and it's important to provide that to help maintain good bladder and vaginal health. Certainly smoking, smoking can also lead to chronic cough situations that can cause incontinence, comorbidities such as diabetes, UTIs. high impact exercises, running, jumping, lifting heavy weights, all of these things can contribute to it. And caffeine and alcohol, just by being bladder irritants and diuretics, can increase the risk for incontinence. So we talked about this briefly. We have three different types of incontinence. We have stress urinary incontinence, we have urge urinary incontinence, and mixed incontinence. And overactive bladder is kind of like this. So overactive bladder is urge incontinence where they're not leaking, whereas urge incontinence is where they have overactive bladder and they are leaking urine. So do you struggle with leaks when you sneeze, exercise, laugh, cough, walk? If you answered yes to any of these questions, you may have what's called a stress urinary incontinence. And as we talked about, the purpose of the bladder is to hold urine. And when you go to urinate, the urethra relaxes and the bladder muscle contracts, which then allows urine to flow out. But in stress urinary incontinence, while the bladder is filling, either the urethra is weak and it doesn't close fully, which allows small amounts of urine to leak, or the urethra is hypermobile, it moves excessively, such that with those activities, it drops the bladder and neck in from the abdomen into the vaginal area and allows incontinence to take place. So there are two different types. So the prevalence of stress incontinence, it affects 1 in 3 women at some point in their lives. It can affect them mentally, physically, by missing out on work and family, and also financially. Physically, it can affect their skin conditions. They're chronically wet, wearing pads, and issues, developing dermatological disorders and changes in irritation. And then a lot of times people are shunned and ostracized from their home because people just don't want to have an incontinent individual in the house making their house smell like urine. So then these individuals get sent off to nursing homes. And then when you go to a nursing home, what do you find there? You find rampantly that there's a smell of urine everywhere. And it's from urinary incontinence, and these are things which absolutely need to be evaluated, managed, and treated. So there are two types of stress urinary incontinence, as I alluded to. One is called hypermobility, so urethral hypermobility, where the bladder neck moves excessively. And the other one is called intrinsic sphincter deficiency, ISD. So in here you see a normal urethra and it's pretty well closed, but when that urethra at rest is not closed, that's called intrinsic sphincter deficiency. So the normal bladder function is for it to fill throughout the day. Nerve signals then lead to stimulation of the bladder, cause it to contract, cause the bladder to contract and the urethra to relax, and micturition to take place. So lack of control of this, can affect your ability to go on trips, missing shows, always looking for bathrooms, not engaging in your normal activities. Your symptoms can include also sudden urge and need to void. You can also have urinary retention. So if things aren't working correctly, you're unable to empty your bladder. A lot of times people will have prolapse with urethral kink and obstruction of their urethra. That can cause it. And fecal incontinence also. All of these conditions can be very well treated and managed. But the most important thing is to actually diagnose them and to recognize them and to own up to them. So OAB, again, is the frequent and urgent need to empty your bladder, which results at times in unintentional urine loss. Frequency is just going more. And realistically, the 8 or more times a day, it's not an absolute number. It's whatever is bothersome for the individual, the patient. Urgency is the need to suddenly and urgently go to the bathroom without having control. Urge incontinence is the involuntary leakage of urine, loss of urine. And nocturia is actually even waking up once at night is abnormal. You really need to get a good solid 7 to 9 hours of sleep. And if you're waking up even once in the middle of the night and it's disrupting your sleep, that's abnormal. It's an estimated 50 million people in the United States alone have overactive bladder. And less than half of those have severe symptoms and seek some form of treatment for it. And if you actually add in fecal incontinence, that adds an additional 20 million people who suffer. So overactive bladders and an abnormal communication between the brain and the bladder, it leads to this sudden urgent need to urinate with unwanted desired bladder contractions, with either sudden rushes to the bathroom or sudden loss of urine. And as with stress incontinence, this also has a significant impact physically, socially, psychologically, sexually, and domestically. You know, you're unable to partake in physical activities. You don't go out and meet with friends and stuff. You feel depressed. You have a sense of low value and self-respect and well-being. It's not uncommon to start avoiding being intimate with your partner for fear of having incontinence while you're being intimate with your partner. And certainly absence from work and decreased productivity all factor into impairing your quality of life. So I think I've already touched upon why seek care, but it's an important part. You know, I think the biggest problem with incontinence, which people have, is they don't own up to it, and there are a lot of misconceptions associated with it, that nothing can be done to treat incontinence in elderly. It's a normal part of aging, especially in older women. If you drink less, that will just automatically take care of the problem. That pads are the only option to manage urinary incontinence, and that if you do require surgery, that it requires large incisions and prolonged recovery. All of these are myths and fallacies, and we'll certainly hopefully dispel them as we go through the presentation. It's one of the more underreported conditions in healthcare, incontinence. And boy, we see this all the time outside of women's bathrooms, right? There's a long line of women waiting to go to the bathroom. Now, is that long line just because women take long in the bathroom, or women are just lining up because they're afraid when they're going to need to go, it's not going to be available? Who knows? Maybe it's a combination of both. On average, it takes women 6.5 years to seek care. That means from the time they develop incontinence to the first time they actually recognize it and discuss it with a healthcare provider. That's a huge time, 6.5 years. Okay. Many cases of incontinence just progress over time from mild to more severe to actually debilitating symptoms. And it's usually not until they're severe or debilitating that women actually seek treatment and management for this. So what is the impact over an individual's life? So here's a hypothetical patient, Jane. She's born, she's young and active. She gets married at the age of 21, has a child at 23. This must be a different population. I think everyone's getting married and having children later on in life nowadays. But first child, 23, second at 25, third at 28, living an active family life. And even during these childbirths, first, second, and third, usually women start experiencing some degree of incontinence. By the time they're getting to 50, they're trying to be active, but now incontinence is becoming a much bigger problem for them. They're reverting to poison, incontinent pads. Now menopause hits. They've lost the estrogen that they used to have. That estrogen kind of worked on the vaginal and the urogenital region to maintain better health. And now suddenly their incontinence has significantly increased. Now at the age of 60, they're kind of like going back to being a child, having to wear not just poised pads, but Depends underwears and diapers, Now, because of all of these things, they're no longer physically active and engaging in normal life's activities. So with them becoming more and more sedentary, they're gaining weight. And now this becomes a vicious cycle, that they're not active, they're gaining weight because of the incontinence. They're continuing to be inactive, continue to gain weight. It just kind of feeds upon itself. As they continue to get older, now they're trying to even get out of bed, walk, and they're going to have falls, potential fractures, and still continue to be incontinent in spite of all of that. So this is it's a pretty realistic but somewhat bleak outlook. But the good news is, with non-surgical treatments, most women with incontinence, their symptoms can be improved. So how do we treat leakage? There are a multitude of pathways, but the simplest first one is just pelvic floor exercise. And there are a variety of different products out there that help you do that. So pelvic floor muscle training, that's the first thing that you do. You can do it with a physical therapist. You can do it on your own. You can do it with the aid of some new devices which are available. If those simple behavioral and physical training, pelvic floor muscle training protocols don't work, then you can go to second line and more advanced third line therapies, which I will talk about through the course of my presentation as well. So the first is just simple Kegel exercises. You're strengthening your pelvic floor. You're doing contractions of your levator muscles to contract them, to hold and support your bladder and your urethra so you don't have sudden leakage of urine. The biggest problem with this is most people don't do them correctly. Most people, when they're doing Kegel exercises, are contracting their abdominal muscles rather than their pelvic floor muscles. And that only makes the problem worse. So we got some biofeedback treatment options also. Actually, the simplest non-surgical treatment option for incontinence is placement of a pessary. So this is showing like a pacifier-like device which goes into the vagina. And as you can see, it's creating a little obstruction to the urethra, and that actually prevents leakage of urine. But pessaries come in a multitude of sizes, shapes, and they can work for prolapse in addition to incontinence. So they're a great simple way of managing both these issues with a single device. The problem with pelvic floor exercises, only 25% of women who have pelvic floor disorders actually perform these pelvic floor exercises. And of those, only 25% do them correctly. So realistically, we're looking at 1 out of 20 people, 5% of people who are probably doing these correctly, or 1 out of 16 people, it's about 8% that are doing these correctly. Okay. We have a couple of simple systems which patients can use on their own. There's small cost associated with them in buying them, but there's one system called Leva. It's a wand-like device which you place in the vagina. It's you use it for 5 minutes a day for 12 weeks. You use it in the privacy of your own home on your own schedule. There are no drugs. There's no surgery. You call in and speak to a coach. They have good data. People have dropped their leakage from 2 leaks a day to about 2 leaks per week. And people start seeing improvements as early as 4 weeks into treatment. So this is what the Leva device looks like. It's got a little motion sensor. It comes with an app that you install on your smartphone. You talk to these coaches, and basically it guides you into contracting your pelvic floor muscles and has you do them correctly. The other is this Innovo incontinence shorts. These are basically shorts that you put on. They have electrodes inside them. You attach them to this device, and this actually does the Kegel exercises for you. So without you doing them, it's a nerve stimulator, which then causes muscles to contract. It helps you strengthen your pelvic floor. And with this, in 30 minutes, you'll do 180 perfect Kegel exercises. 87% are dry or nearly dry after 12 weeks, and 90% of patients will recommend it to others. So it's a fairly simple non-surgical option. Now, what are the other treatment options for stress incontinence? We've already talked about the pessary, biofeedback, physical therapy, and pelvic floor exercises. So the next ones are these minimally invasive options of urethral bulking or suburethral slings. And then the more invasive options are bladder neck suspensions, MMK, Birch procedures. Okay. So these are the minimally invasive options for stress incontinence. This is basically going in with no cuts or incisions whatsoever through the urethra into the proximal urethra. That's the part of the urethra very close to the bladder, and just inserting a needle into that area right next to the bladder neck and injecting this bulking material. And what that bulking material does is it takes what's previously an open urethra and now increases the coaptation to reduce the diameter, and that reduces the amount of incontinence that one has. The next is this mid-urethral sling or suburethral sling. So mesh slings have been around since 1968. They were first approved for you in the USA in 1998. It's really the placement of it's a minimally invasive procedure. There are lots of different ways of doing it. There's you can make 2 small incisions suprapubically and pass two needles, make a small dissection in the vagina, and attach a piece of mesh, pull it into position, adjust it, and suture up the vaginal mucosa. There are even less invasive ones which go into the obturator foramen, or a single incision ones where you only make the vaginal incision. These are considered the gold standard treatment for stress urinary incontinence, and they have a cure rate of 90 to 95% in good hands. So this is basically showing you a picture of that. Here's the bladder, the urethra, and this is that piece of tape, mesh tape that goes underneath it. It acts like a hammock to your urethra, and effectively what it does is it creates a kink in your urethra when you cough, strain, lift, things like that. So these are the three different things: treatment for stress urinary incontinence, exercises, surgical sling, bulking, and surgical sling. So this is showing you can also do Kegel exercises by going in into a bridge pose here. This is the sling procedure again, bladder, urethra, and this is showing a transobturator approach. This is the obturator foramen, and the mesh goes underneath it, basically acts as a cradle to hold and support the urethra and prevent incontinence. And this is the bulking, where you inject a bulking material into the proximal urethra. This is kind of showing you a little better image. Bulkamid is one of the agents that's used for bulking, and I think it's probably the preferred agent at this point. So this is what the urethra would look like, and you're basically taking a larger diameter opening by injecting this bulking material, making it into a smaller diameter opening. So now we'll talk a little bit about urge incontinence. So the pelvic floor exercises, the Leva and the Innovo, they work for stress incontinence, but they also work for urge incontinence, and they also work for mixed incontinence. So the next line treatments for urge incontinence is oral medications. There's a whole host of different oral medications. There are two big groups of oral medications, one which are anticholinergic and the ones which are beta adrenergic. The anticholinergic ones work on the bladder to relax it. The beta agonists also work to prevent contraction of the bladder. The minimally invasive options for OAB are these Botox. So just as you get Botox on your face to paralyze some of the muscles on the face, to prevent the wrinkles on your face, here you're actually injecting Botox into the bladder muscle itself, and that paralyzes the bladder muscle and prevents it from being overactive. We have other ways of doing that also. One is called a percutaneous tibial nerve stimulation. You basically have a little pin that's placed on your toe and the heel, and you're stimulating the S3 nerve from there. By stimulating the S3 nerve, that's the same nerve that innervates the bladder. You downregulate the overactivity of that nerve, and it leads to improvements in urge incontinence symptoms. Sacral nerve stimulation is the same as percutaneous tibial nerve, but percutaneous tibial nerve, you need to come into the office to have the procedure performed on a weekly basis. With sacral nerve stimulation, you just have a device implanted that just constantly keeps stimulating the nerve for you. So first is consult your doctor. Initial treatment, conservatively, no trial of medications. If none of those things work, then sacral neuromodulation, percutaneous tibial nerve stimulation, and Botox are the treatments. So beta adrenergics promote bladder relaxation. Anticholinergics block detrusor contraction. Lifestyle changes, you can limit your fluid intake, carbonated beverages, caffeine, limit alcohol, eating a vitamin-rich diet. Pelvic floor bladder training exercises could be such as pelvic floor relaxation, Kegel exercises, putting yourself on a time voiding schedule. So all of these things can be helpful. If that doesn't work, this is what the percutaneous tibial nerve stimulation is. You're putting a little electrode on your heel and the return electrode on your toe, and it basically innervates and stimulates that same nerve that goes to your bladder. You do 12 weekly in-office sessions. You can usually start seeing some benefit after 5 to 6 sessions. And after 12 sessions, if it's working for you, then you go on long-term maintenance treatment with it monthly. This shows what happens when you inject Botox into the bladder. Small little needle goes into the bladder muscle, and you're injecting small amounts of Botox to prevent the bladder muscle from being overactive. And this is sacral neuromodulation. This is, again, going to the nerve, S3 nerve that innervates the bladder. It's associated with this small little implant, which keeps stimulating that, that nerve, which downregulates that bladder overactivity for you. The typical way of doing this is you do an in-office trial procedure called a PNE, percutaneous nerve evaluation. If we find that the nerve test is successful, then you go into the office, have a small procedure done. The only incision involved is about 1 inch for the placement of this device under your skin. The other one is just a small needle, which is introduced. This thing can last for 15 years. We have rechargeable devices and non-rechargeable devices. Axonics is one of the companies that makes these sacral neuromodulation. It's the newest product there. It's MRI compatible and safe. It's extremely small, portable. It's rechargeable. 93% of patients achieved clinically significant improvements in incontinence at 2 years. 94% were satisfied. 93% would do it again after 2 years. So how do you reduce the likelihood and severity of incontinence? Eat plenty of fiber and decrease your fluids, especially bladder irritants. Move, exercise, lose weight, quit smoking. These are all simple things that can significantly help. So many women with bladder control problems are reluctant to discuss them with anyone. They're embarrassed to acknowledge that they even have a problem. They feel embarrassed or ashamed for no fault of their own. And many think that it's a condition that's not treatable. They think that it's just going to be a waste of time. And others think it's a normal part of aging. It is not a normal part of aging. There is nothing normal about being incontinent. The truth is, urinary incontinence can have a very significant impact. It can undermine your sense of well-being and worth. It impacts your ability to engage in exercising, physical and social activities. It impacts your work, travel, and intimacy. All of these things are very important. They don't kill you, but they rob you of your life little by little by little until life doesn't become worth living any longer, So 80 to 90% of women who seek treatment get improvement. Recommend you see a urogynecologist or female urologist. They'll work with you on lifestyle, dietary, medications, nerve stimulation, or minimally invasive treatment options, whichever are the best for you. But the most important thing is educate yourself, get evaluated, and then if treatment is appropriate, get treated. Are you ready for symptom relief? Schedule a consultation, trial the various therapies that are available. Ultimately, we can make a difference in our patients' lives. This is a thank you note I received from a patient of mine. It says, Dr. Murchie, I want to thank you from the bottom of my heart for giving me my life back. I think that speaks to the problem that we are facing here. People, it robs them of their ability to function and carry on. You're the only doctor that found my problem. You're the 5th urologist since 2002 that I've seen for this problem, and are the only one to spot my 35-year mess. I am 9 weeks out of surgery and feeling great. You are an amazing and caring doctor, and I thank you. And I thank God I found you. So this makes working, doing what I do worthwhile. So it's really wonderful to receive notes like this. And I'm so grateful that I have the ability to help out in this manner. So UI is not an inevitable part of aging. It doesn't have to be. Through lifestyle changes, we can treat, minimize its impact. We can manage by managing our fluid intake, the types of fluids, avoiding bladder irritants, eating diets which are full of fiber, preventing ourselves from being constipated, exercising, strengthening our pelvic floor muscles and our body in general, doing bladder training, time voids. If we're overweight, losing weight, our ideal BMI, although that range is from 18.5 to 25, the ideal BMI is 22. If we're able to do all of this, we can certainly fight and prevent this inevitable part of aging and check it and not be victims to it. So if you have any of these things, seek evaluation and management. Take the next steps. Thank you.
Thank you, Dr. Marcia. This was very, very informative session. And I'm sure that people who are here today to listen to this talk, they must have gained a lot of information, but also it'll be recorded. So it'll be open for everyone to check on this. I do have a couple of questions before we ask our, the viewers to ask. What actually causes this, all the senior nocturnal enuresis?
The nocturnal. So I think a lot of this is associated with difficulty and inability for people to move, to get out of bed, to walk. Certainly it can be associated with medications that they're taking. Okay. So I think nocturnal enuresis, it's a multifaceted thing. Either it's fluid intake before you go to bed, or it's medications that you're taking, or it could actually even be sleep apnea. It may not be anything with your bladder. It could be just you have obstructive sleep apnea and you're waking up in the middle of the night to go to the bathroom thinking, I have to pee, but it's not that your need to void, it's your need to start breathing again.
And actually, today's talk, we learned a lot about, of course, the incontinence in women, but basically coming to men, what are the main causes of male incontinence? Because the percentage is less.
For men, the biggest thing is usually prostate surgery, BPH, then some kind of prostatic surgery. Either it's a TURP where they have resection of the prostate, or if they have prostate cancer, they have removal of the prostate, and that leads to a fair bit of incontinence for them. That's usually the biggest factor for males.
And Dr. Marcia, you were explaining about the pessary, right? About all the pessary things. So how long does a pessary stay in? I mean, can it even affect the bowel movements?
So if it's too large, it can be obstructive so that it can prevent you from having bowel movements. But then again, you would have to say that maybe your stool are extremely hard, and that's why they're not negotiating their way past the pessary. So, constipation is indeed a very big problem that's associated with it. Pessaries can actually stay in for a reasonable amount of time. They can stay in for weeks or months, but they should be cleaned. You don't want to leave them and forget about them indefinitely. If you're not providing adequate vaginal health maintenance, it can, over long periods of time, lead to erosions and ulcerations in the vaginal mucosa. So it's usually recommended that they use some vaginal estrogen to improve vaginal health.
Okay. And also about coming to fecal incontinence, I know that we were talking, today's discussion was more about urinary, but how can one deal with fecal incontinence in elderly?
So again, fecal incontinence can be associated with constipation or diarrhea, big things. It can also be associated with poor anal sphincter tone, okay? So the first thing is dietary changes. Fiber is the great modulator, the great mediator, if you will. If your stool is too soft, eating more fiber is going to bulk it up and make it less watery. If your stool is very hard and you're constipated, eating more fiber is going to draw more fluid into your colon and it's going to soften it up. So you can't get enough of fiber. Our food is just so devoid of fiber that constipation is a incredible problem for most people. So going back to a whole food plant-based diet, I think is extremely, extremely important to manage the constipation. And from that, a whole host of other problems. Now, suppose you get the stool part of it under control, and now you're not having watery diarrhea or rock hard constipation, and now you're still having fecal incontinence. There are things which can be done to improve. So if you have a disrupted anal sphincter, you can certainly have that surgically corrected and reapproximated. If your anal sphincter is intact, but you're still having inappropriate bowel, you can actually go for pelvic floor exercises where they can work with you to strengthen your pelvic floor muscles and your anal sphincter and your rectal muscles so that you have better tonicity. Sometimes simply using something as simple as a squatty potty can help change the angulation of your rectal sling, which is basically the puborectal sling, which is providing continence for you. So by changing that angle, it'll allow you to defecate better and be able to have better bowel movements. The sacral neuromodulation, the sacral nerve stimulation system also works incredibly well for people who have fecal urgency and fecal incontinence, which is not necessarily associated with diarrhea or constipation.
And Dr. Murshi, actually, when I was, trying to interact some of the seniors, I felt that one of the top changes of aging, or age-associated conditions, all these things, like incontinence, I felt like, it also worsens their limitations in mobility, or, does it even, is my question too, is it also affecting their cognitive impairment? Or it is only caused because of certain reasons, as you were also talking about some part where genetics come into picture. But is it that, or is it also a part of, it's caused by anxiety?
Well, I think it's the question of what came first, the chicken or the egg, as we were talking previously in terms of, it doesn't kill you, but it robs you of your life. It robs you of your ability to exercise. It robs you of your ability to maintain good tone, muscle tone, body function, so as you're not able to engage in activities, you become weak. As you become weak, you're unable to even do simple things as get out of bed. Certainly there can be other confounding factors. Also, medications. We talked about a variety of different medicines that can make you sedated or depressed or immobile. So all those things can certainly contribute to it. And just I think the greatest thing that we can do in our lives to prevent aging is to keep moving. If we keep moving, we keep our body and our muscles in tone. Our musculoskeletal system is the thing that makes us mobile. It makes us go from one place to another. And we need to be able to do that for everything, from even simple things as getting out of the bed and going to the bathroom, or getting out of a chair and going to the bathroom, because we don't want to make our bathroom everywhere we are.
Right. Also, I was reading about this behavioral therapy. Does it also help for overactive bladder?
It does. It absolutely does. So timed voids, and just focusing on when you want to go and when you don't want to go, through timed voids can be very, very helpful. Certainly factoring in and avoiding bladder irritants and fluids that are going to irritate your bladder. One of the things which we kind of talk about is specific bladder irritants, like coffee and tea and citrus fruits and stuff like that. But what we really want to think about are things that lead to acidosis in our body. If the foods that we eat, if they lead to acidosis in our body, it leads to aciduria in our urine, okay? And that leads to significant bladder irritation. The normal pH in our bodies is 7.4, okay? If it's less than that, we're working in an acidic environment. If it's greater than that, then we're in an alkalotic environment. If we're looking at foods which we eat, it's not that if you eat an orange, you're going to absorb that acidity of the orange, and that's going to lead to acidemia in your body, because our stomach is an extraordinarily acidic environment. The pH in our stomach is about a 2 or a 3. So our body is a 7.4. The pH in our stomach is a 2 or a 3. So whatever orange we eat, it's definitely higher than a 2 or 3. The pH in our stomach basically helps break down all the foods that we eat into really small micromolecules so that they can be absorbed. And once they're absorbed, that's where the process takes place. Now, depending on the foods we eat, how quickly we eat, whether we adequately chew our food or not, it can lead to potentially a leaky gut. Leaky guts can then lead to larger macromolecules which get absorbed through the gut mucosa, which can then lead to autoimmune disorders, but that can also lead to acidosis in our body. And that acidemia can lead to aciduria in the bladder, which can then lead to bladder irritation. So it's this whole process. So it starts from the very simple thing of what we put in our mouth, the food that we consume, how we consume our food, how we chew it, how we swallow it, how we digest it, and what we eat. All of those things kind of factor into this. And unfortunately, in this day and age, we pretty much eat mostly processed foods. We have a diet which is highly focused on an animal protein diet, and that animal protein does not get broken down well. When it gets absorbed, it leads to acidosis, acidemia in our body, and it also leads to a great deal of autoimmune disorders. So going to a whole food plant-based diet where you're not eating foods that are going to promote a leaky gut, allow this autoimmune, allow this acidemia and acidosis and aciduria all to develop, is how you're going to actually even lead to general overall health and as well as improved bladder health.
Interesting. Dr. Marsha, this will be my last question because I know there may be others having other questions to ask you. There are different forms that urinary incontinence can take. As I was listening to your presentation, and the reasoning behind the leaks, it varies, right, from person to person. But while some forms of leaks can be linked to physical changes in our bodies, but there are also certain forms that develop as a result of probably lack of mental function. So how can we tell the difference, basically when seniors have that, and how can we find out what's the real difference and how can they go to get help to improve the overall quality of life, which of course you explained, but I'm trying to find out this part too. Like, how do you find the difference part?
Yeah, I think most people go through toilet training when they're young, so they know how and when to use the bathroom, how and when they need to go to the bathroom. So when we're talking about older people no longer having that capacity to make it to the bathroom, either it's the medications that they're on that they're now obtunded. So polypharmacy is a big, huge problem in the elderly, and the compounding effects of all the drugs and medications that they're on can make them so sedated and dysfunctional that they can't function. Two, immobility in and of itself, it's too challenging for them to get up and go, and at some point it's not worth it for them any longer, and they just have accidents or void voluntarily on themselves because they just physically don't have the strength to do it. So reduction in medications, improved physical activity, I think those are extremely important. So if you have a patient that you can't determine what's the cause of incontinence for them, and they're just not very engaging or responsive, the first thing I would do is look at the medications that they're on. They may be on some psychotropic medications which have left them in this rather obtunded state, and because of that, now they're just not even engaging and interacting with the world.
Right. Thank you so much, Dr. Marcia. We had a wonderful, very wonderful, honestly speaking, presentation today. I learned a lot, and I'm pretty sure everyone must have learned. Just for me, for everyone, just putting it all together, it's a symptom. It's a sign that something is wrong. Treatment can definitely improve, but it cannot not always cure the symptom. And as Dr. Marcia was saying, there are ways to help to manage this incontinence. The very first step is to recognize that something is wrong and immediately go and seek help. While incontinence is pretty common as we age, it's not a normal part of aging. Unfortunately, too many people, they wait too long. And even with my interaction, I saw they don't want to talk about it. So they don't even want to talk to their healthcare team. We would say that it would be better that they need to talk, and there are different treatment options, as Dr. Marcia explained to everything, which can have positive impact on the quality of one's life. So I would again say that don't hesitate to discuss with your healthcare provider. And also as a family caregiver, who I am myself a family caregiver, and I would advise it to other caregivers too, it may be necessary for you to take the lead in addressing this problem. So one needs to Help your loved ones realize that this condition need not be the cause for shame, but rather it should be viewed as a treatable medical problem. Helping one's loved one deal with this type of incontinence can improve the quality of life for both of you. So as per as, again, just talking a little bit about our organization, our goal is to Volunteering for Seniors goal is to connect people to resources like we had today that promote aging with complete independence and increase community awareness of aging issues and generating community-based solutions to all these issues. Dr. Marcia, before I end today's webinar, is there anything that you want to say, any key point that you would love to tell to our viewers?
I think I've shared a fair bit. I want to thank you for inviting me, and it was my pleasure to partake in the activity today. Thank you.
Thank you. Thank you very much. Thank you, everyone, for attending our webinar tonight on diagnosis and treatment of urinary incontinence. And in case, again, you missed it, you can please watch it on our VFS YouTube channel. Thank you.
Thank you.